I'm here with Andrew Iwach, and we're here to talk about the state of glaucoma treatments and the future of glaucoma treatments. The past 10 years, there's been a lot of excitement, a lot of introduction of new technology, MIGS obviously. We're seeing just recently an approval of a better daily eye drop for glaucoma, starting to get into neurotechnology and home monitoring technology. Could you just give me in a quick encapsulation, what have the past 10 years meant for you as a glaucoma specialist?
Well, it's really helped us help patients because we have a lot more tools. Number one, to determine the state of the disease, we have better diagnostic instruments to help us look for trends or progression. That information is critical because then we can modulate or customize what we do for our patients. Mm-hmm. Unfortunately, most of our interventions certainly have some inconvenience and potential side effects. So it's very important to determine who really needs treatment, how much treatment, to minimize the impact of the disease today on their quality of life, while at the same time keeping them seeing for the rest of their life. And part of that discussion is taking into account their age, their health status, to make sure that we're not over-treating and at the same time not under-treating as we are living longer. And so medications have played a huge role with the introduction of prostaglandin analogs. When we look at our data, the number of filtering surgeries has really dropped off significantly, and it seems to correlate with that. With newer lasers such as SLT, likewise, it appears to have influenced our need to have to use the more invasive surgery. So definitely new interventions help us help our patients in a kinder, gentler way.
And I don't like the term the Holy Grail, but is the Holy Grail for treatment really getting that earlier diagnosis? And how do you do that as a glaucoma specialist? Because they're not in your office, you're not seeing them because they haven't been identified as potentially having glaucoma yet.
So it's important, the American Academy of Ophthalmology has a straight out recommendation. If by age 40 you have not had an eye examination, get one. Mm-hmm. And then if you have symptoms, go get seen right away. So it's really important to have that preventative first look, and we then develop a risk assessment, and from that we can say, we need to be seen in a year or 2 years, depending on the state of the disease and the risk profile. So early screening is important. There are a variety of ways to do that. Having said that, we have to then identify at what level the risk is for vision loss, for example, from glaucoma. And these other technologies help us kind of figure out who is really, really at a higher risk versus those that may be at a lower risk and don't need as close of a follow-up. Mm-hmm. Then finally, as we go forward, for those in whom we're really concerned could have vision loss during their lifetime, then we look at the different options that we have to help them. And the only approved methods currently are by lowering intraocular pressure.
Sure. So looking forward, how does glaucoma treatment change over the next decade?
We have some new opportunities in the pharmaceuticals. A new drug was just approved recently. Mm-hmm. Another one looks like on the horizon. The half-life, we're looking for drops that can be used once a day, ideally. It'd be nice to have it once a week or once a month. Some of the extended release systems are making their way through the system, so it would be nice that if a patient came in every few months, we would do something around their eye, in their eyelid, or in the eye, or around the eye, so they wouldn't have to take drops every day. The fact of convenience is important, but the way these systems work is it's almost like a drip irrigation system. So we have molecules now that we would like to use, but because they have such a short half-life, we have to get a high peak dose, so they're not practical. But if we could slowly drip in the molecules slowly at a lower rate, that may quickly open up other molecules that we currently cannot use. We have newer lasers that we're looking at that also try to lower the intraocular pressure from a variety of techniques. We're still studying those. And in the surgical step, unfortunately, glaucoma isn't the only problem they're dealing with. Often it's cataract. So when patients do go for cataract surgery, that offers a unique opportunity to surgically address glaucoma. And that's where the MIGS have really come in to play an important role.
And are we seeing other technologies come in? I know we'll have a neuromodulation company presenting today. I'm not sure, you may not be familiar with that yet. It's fairly early stage, but what is out there on the non-device, non-pharmaceutical front?
There are newer ways to monitor remotely glaucoma patients, for example. And it has to be taken into context. I think that there's still going to be an important role for the eye care professional to serve as the coach, to oversee all these different pieces of information. And so home monitoring of intraocular pressure, there is a new device that has been approved here in the United States, which will be very good for some patients. But at the same time, as we look at these new tools, we want to match it to the right patient and the need. The glaucoma, for example, usually patients don't have symptoms. And so what we're trying to do is keep them seeing for the rest of their life. And so we want to devise a treatment program that includes a combination, whether it be drops or laser treatments, as well as diagnostics, so that they don't so the disease doesn't take over their life unnecessarily. So currently, for many patients, our current routines of checking pressures and imaging and field testing and all the different things we have give us enough information to adequately monitor and help most patients. We certainly can do better. But at the same time, as we look at these new technologies, we want to also carefully look at the impact on their quality of life to make sure that we're not overburdening our patients. And so I'm really excited about some of the new technologies available that, for example, with field testing, it may be instead of sitting in this bowl in an office, that we'll be sending them a pair of goggles at home that they'll, at their convenience, put on. Maybe we'll have virtual reality testing that will really more, in a practical sense, show what is this disease doing to you on different activities. This has been looked at, but I think as the technology becomes more mobile, less expensive, it'll become more practical. And so as we assess our role in helping patients, we'll have newer benchmarks, and I think that's important.
It's an exciting 10 years to come.
It is.
Excellent.
Thank you.